Thank you and welcome everyone to our Research Connect series. I'm Sherry Logan, a CDTRP PFD partner. I will be facilitating today's webinar. I'm the founder of Ashley's Angels, a third-party fundraising initiative in support of the transplant program at the Hospital for Sick Kids, which I formed following my daughter's liver transplant in 2009. Along with my role as patient partner with CDTRP, I also actively am involved with the Society of Pediatric Liver Transplantation, Patients and Family Engaged Partners, Starzl Network, Trillium Gift of Life, and the Canadian Institute of Health Research. I'm currently pursuing a Master's of Public Health and Health Promotion at the University of Alberta. First, I would like to acknowledge that CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dean, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. We are honored to be an uninvited guest on this land and appreciate the ability to work, rest, and play while we are here and leaving the territory as it was when we arrived. I encourage you to write your land acknowledgements in the chat box. We would also like to acknowledge Astellas, Takeda, and AstraZeneca. Without those generous support, we would not be able to host these sessions. The CDTRP also relies on the generous support of our community. Your gift ensures we can focus on delivering our mission of supporting excellence in donation and transplantation research. There will be a link in the chat box to donate. Before we dive into the main content, I will pass it over to Erica for some general CDTRP updates.
Hi there. I would like to announce that we will be launching the 2023 Research Innovation Grant Competition. This year, we're really happy to be able to provide 12 different grants, each of 30K, from 9 different partners. These partners include TRFBC, the Kidney Foundation, Big Gifts for Little Lives, the Alberta Transplant Institute, Paladin, University Health Network Multi-Organ Transplant Program, the London Health Network Multi-Organ Transplant Program, Université de Montréal, Sick Kids Transplant, and Regenerative Medicine, the Center. The application deadline is April 12th. I'm going to put a link in the chat. And to mention, there's going to be something new this year, is that PFDs will be judging the competition instead of just providing feedback. So thank you very much.
Before I introduce the speakers, I have a few housekeeping notes. Today's session is being recorded and will be posted on the CDTRP website and YouTube channel. During the presentation, we kindly request that you keep your mics off, but we encourage you to turn your cameras on. And if you have a question or comment, to ask our presenter directly. I am pleased to be introducing our presenters, Dr. Lorraine Hamiwka and Laurie Lee. Dr. Lorraine Hamiwka is an associate professor at the University of Calgary Cumming School of Medicine and a pediatric nephrologist at the Alberta Children's Hospital. She is the past chair of the Pediatric Group of the Canadian Society of Transplantation. She is the director of the Pediatric Kidney Transplant Program at the Alberta's Children's Hospital and leads the Young Adult Kidney Transplant Clinic in Calgary, designed to improve young adult kidney transplant recipients' healthcare experience. Her research includes pediatric transplantation, quality of life, and long-term health outcomes. Dr. Hamiwka is currently involved and supports several national multi-center transplant research projects, as well as many national initiatives. Laurie Lee is a pediatric nurse practitioner in the Pediatric Intensive Unit at the Alberta Children's Hospital. She successfully implemented the Alberta Children's Hospital PICU Outreach Rapid Response Team, the Alberta Children's Hospital Donation After Cardiac Death Program, as well as the PICU Pain, Agitation, and Delirium Prevention Program, which she continues to lead. Laurie has 18 years of experience as a pediatric critical care practitioner in Canada, USA, Bermuda, and the United Kingdom, 10 of which have been in the nurse practitioner role. She has a strong collaborative clinical practice as well as an active role in quality improvement, education, program development, and clinical research. I'll turn it over to you.
Great, thank you so much for the kind introductions. Just making sure that everybody can hear me okay. So it's my honor to present this survey on the current practices of pediatric and neonatal donation and transplant in Canada. Dr. Hamiwka and I are representing a larger team that I'll get to in a second. So really this work started once we recognized a real lack of improvement in pediatric donation and transplant in Canada. So many of you may recall in 2011, Canadian Blood Services collaborated on a plan to improve donation and transplantation for all Canadians. And since then, there's been a steady increase in donation in adults with a corresponding decrease in transplant waitlists. However, as you can see on the slide shown here, the same improvements have not been translated in the pediatric population. And when we look from 2007 to 2021 in the graph on the top, we can see that donation rates, despite increases in DCD donation, have actually fallen from children in Canada. And the number of organs that were transplanted maybe a little bit up, but nothing substantially. When we look at wait lists, we see a similar trend in the last 5 years, where though there's some ups and downs, there's been no significant change in the number of children awaiting organs in Canada. And so in looking at this data, a group of us got together initially in 2019 to really identify where we needed to go and what we needed to do to improve donation and transplant rates for children in Canada. And we're going to present to you the results of one portion of this, which was really a environmental scan of the current status of the programs in Canada. And this work is led by 4 of us from the donation and transplant community. And Lorraine and I are honored to be able to present these results today. So one of the first things we identified was a real need to understand the current state. And through bringing everyone together to one table, we realized that looking at organ donation organizations, transplant programs, and critical care units separately really wouldn't answer the questions. We know that each of these programs and their current standards and practices affect others. And the best example for that is there was a shared sentiment that practitioners in the critical care units were reluctant at times to approach families to offer donation because they had concerns about whether the organs would be accepted by either the ODOs or transplant programs. And transplant programs had concerns about whether families were being approached. So though these are separate arm's length organizations, we recognize the need to work together to develop surveys so that all of the information gathered was cohesive. So we surveyed all Canadian pediatric intensive care units, a selection of neonatal intensive care units, pediatric transplant programs, and Canadian organ donation organizations. And so I'm going to present to you the results of the critical care units and the ODOs, and then Lorraine will talk about the transplant programs. So we offered surveys to 16 PICUs in Canada, and 15 of them completed it. And these all 16 were the PICUs that do have donation in their units. And then we offered to 32 level 4 NICUs, and only 14 or 44% completed it, which actually isn't that surprising because we know that the culture of donation in NICUs is not where we would like it to be, and our survey results will show more of that shortly. So in looking at these, in terms of the types of donation offered in critical care units in Canada, for children in PICUs who die by neurological criteria, 14 of the 15 units routinely offer donation to all families. And the one that doesn't routinely says that for children who die by neurological criteria, they don't have specific policies in place, but they would facilitate donation if the family requested it. 12 of the units responded that they test all patients for, oh, I'm sorry, I just skipped many slides for you there. There we go. 12 of the units responded that they test all patients that they suspect death by neurological criteria. And 3 units suggested they only test some of those patients. And the reason that they wouldn't is if the family had in advance indicated they were not interested in pursuing donation and had already agreed to withdrawal of life-sustaining therapies or organ supports. Interestingly, you can see the numbers of donation estimated in the last 3 years by units for patients who died by neurological criteria vary across Canada, with 5 units saying they had 0 to 3 donors, 5 saying they had 4 to 6 donors, 3 units suggesting they had 7 to 10, and only 2 units having more than 10. So still quite rare if you think about, like, some units had 3 donors over 3 years. But you'll see that this is the most common type of donation in critical care units in Canada. When we look at the data for neonates who die by neurological criteria, only 57% of the NICUs who responded indicated that they offer donation to those children. 43% indicated they would not offer donation to children who had died by neurological criteria. Of those that offer, so of that 57%, only 38% have policies in place and routinely offer. Another 38% have policies in place but don't routinely offer. And a quarter don't have any policies, but again suggested that they would facilitate this if a family requested it. For the units that say that they do not offer donation after death by neurological criteria, 4 out of 6 would offer to transfer if a family wanted to donate, but 2 out of 6 said they would just inform the families that that wasn't an opportunity for them. 57% of the units indicated they don't complete DNC testing in their unit, and 36% said they would test if they suspected it, and only 1 indicated they routinely tested for all who suspected it. One thing that's really important to note in the NICU data is this is exceedingly rare, and of the 8 NICUs that suggested they would offer donation after death by neurological criteria, only 1 had had 1 donor in the last 3 years. So very, very rare for this area. So moving on to children who die by circulatory criteria, 13 of the 15 PICUs would offer donation after death by circulatory criteria, and 11 would offer to all eligible families. 2 of those 13 have some policies, but would only do it if a family requested that type of donation. For the units who did not offer DCC donation at the time of our survey, both were working on developing policies to support it, but didn't routinely offer. And of those 2, 1 would offer referral to another site if families were interested, and the other would just inform the family that it wasn't an option for them. And you can see here that the estimated number of donors in the last 3 years was markedly lower for death by circulatory criteria than death by neurological criteria, with 11 of the 13 units indicating that they'd had 0 to 3 DCC donors in the last 3 years. And that's mirrored by the graphs I showed at the beginning, where the number of DCC donors was still quite small. We get even more rare when we talk about DCC in the NICUs. So for neonates who die by circulatory criteria, only 8 of the 14 NICUs reported offering donation. 5 have policies for families who request, and only 1 would offer to all eligible families, and 2 would facilitate if requested, but didn't have any policies in place. All 6 of the NICUs who do not offer donation by DCC have no plans to offer it in the future and would be unwilling to offer transfer to another unit. So again, a big difference in the availability of donation opportunities in the NICU compared to the PICU. So next we looked at identification, referral, and approach in critical care units. So 11 of the 15 responding PICUs reported that mandatory referral exists in their unit, and the criteria was either specific criteria for those 7 units and all deaths for 4 of those units. For the units without mandatory referral, the most common reason for not referring in the context of death by neurological criteria was that the family had declined in advance. Interestingly, the 2 highest ranked reasons for not referring in the context of death by circulatory criteria was again that the family declined in advance, but also ethical objections to death by circulatory criteria. When we talk about who determines the eligibility for referral, 67% of ICUs said that it's the attending physician who determines whether the patient meets the mandatory referral criteria or decides whether to refer. Only 1 unit indicated that the ODO does this. 2 units said that it depends on the day, and 2 said that all patients are referred that die, and so there's no need for someone to determine it. When we again look at this in the neonatal population, only 3 reported mandatory referral. And what's interesting about this is the laws aren't that different from province to province, and they certainly aren't different in NICUs than PICUs. So it's interesting that the interpretation varies. For those with mandatory referral, one NICU cited all deaths. One said that all deaths greater than 36 weeks, and a different one said all deaths greater than 35 weeks. The most common reason the NICU cited for not offering donation was that the neonatologist or attending physician determined that the patient was medically unsuitable. And the second most common reason for not offering donation in the NICU was concern about added burden to the family. Again, predominantly the attending physician determining eligibility in 79% of NICUs. One suggested it was the ODO, and the other two suggested that it varies from case to case. Moving on to looking at donation conversations, in both the PICU and the NICU, the attending physician is the most common individual to first raise the concept of donation with the family. And in those units, 20 to 33% of those attending physicians reported receiving formal training on how to have donation conversations. Looking at sort of culture of donation in critical care units, we asked about donation advocates, education, and training. The majority of PICUs reported having a donation champion, and 62% of those would receive training and education. 13 of 13 had a physician champion, 1 had a nurse practitioner champion, and 2 had RN champions. About half of these were financially supported either by the province or the ODO. And almost 3/4 of all PICUs who responded to our survey do offer donation-specific education to their frontline healthcare providers, with the main targets being nurses, medical trainees, and physicians. Again, not surprisingly, a bit of a different picture in the NICUs, with only 36% of those reporting having a donation champion, all of which are funded by the province, but only 2 of which get provided education. 5 out of the 5 that have champions are physicians, and 1 also has a nurse practitioner. And worryingly, only 1 NICU reported provision of donation-specific education to bedside staff. And so finally, we asked about barriers and facilitators that we hadn't covered in our survey. And the PICUs listed that there was concern that donation in PEDS end-of-life care was an important barrier to donation, lack of dedicated pediatric ODO coordinators, and physician-only referral and approach, as well as resistance to donation after death by circulatory criteria outside of the PICU, that those were important barriers to donation. Things that they felt facilitated it was having regional medical leads supporting best practice, having an on-call support physician from the donation organizations, and having a specific PEDS on-site donor coordinator. The NICUs didn't list any facilitators, but the main barriers they highlighted were a lack of donation culture, historical ethical concerns regarding neonatal donation, a lack of acceptance of organs from small babies by the transplant and organ donation organizations, and a lack of surgical specialization specifically with neonatal-sized organs. We also asked a bit about data and reporting. So we found out that 13 of the 15 PICUs review all deaths for donor potential. These are shared outside of the PICU about half of the time. And the process is quite variable, with ad hoc conversations being the most common action when a missed donor is identified. And again, not surprisingly, in the NICUs, only 1 NICU reported reviewing all deaths for donor potential. So to summarize the critical care surveys, we know that not all Canadian parents have equal access to donation opportunities in Canadian PICUs or NICUs. Most of the PICUs offer routine DNC donation and DCC donation, though not all units routinely offer it to all families. Many NICUs do not offer either type of donation to potentially eligible families. Though most Canadian PICUs endorse mandatory referral, only a quarter of those have inconsistent practices for determining eligibility, and most NICUs do not endorse mandatory referral. Though most Canadian PICUs have donation-based education, few NICUs do. Donation conversations are typically led by the critical care physician, and most of these individuals do not receive specific donation education around these conversations. And most PICUs complete potential donor audits, most NICUs do not. And there's an inconsistent approach to what to do when missed donors are identified. So moving on to the surveys of Canadian organ donation organizations, we invited the administrative leads of all 11 Canadian ODOs, 2 of whom excused themselves from the survey because they don't offer or accept any pediatric or neonatal organs. Those are deferred to adjacent organizations. So we had 9 complete the surveys, which we feel represents the landscape across Canada. So we asked first about donor exclusion criteria. When asked about absolute general pediatric criteria, only 5 of the 9 ODOs had any. Only one element, which was less than 36 weeks gestation, was provided by more than one ODO. And all of the other elements you see listed there were only provided by one ODO. So one said less than 1 year of age, a different one said 2.2 kilos. One said less than 8 kilos if they're out of province, and then the other 2 listed some of the infectious criteria. And you'll see a theme as we move through the ODOs and transplant programs that there's very little consistency reported across these programs. When we asked by organ, not all programs, again, indicated that they had any absolute exclusion criteria. So the N in these is how many of the organ programs responded to this question. It's also important to note that we stopped asking about infectious criteria because that's set by Health Canada. So that's why that's not included in these slides. So you can see for the 2 cardiac programs, none of them reported the same organ. And for the 6 kidney programs that responded to this, none of them reported the same criteria. So variations in age-based exclusion criteria, 1 cardiac program said less than 1 year, 1 said less than 36 weeks. Only 1 listed weight as an absolute. Same thing for lung, the 1 program listed those criteria. And then in the kidneys, each of the 6 programs that responded listed a different absolute exclusion criteria from the ODO perspective. So then we looked at organ offering and utilization. So we asked the ODOs about reasons that they didn't offer out pediatric or neonatal organs, as well as reasons that they had declines to them by the transplant program. And the most commonly cited reasons for the ODO choosing to not offer out the organs were either organ function or quality, which was the most common, followed by the size and weight of the patient, or the fact that the organ was coming from a DCD donor. When asked about reasons transplant programs declined, 8 of the 9 ODOs cited organ function quality and size of the organ. 7 of 9 cited size of the donor or age of the donor and HLA matching. And 6 of the 9 indicated that a reason for decline by transplant programs was that the organ came from a DCD donor. And then reasons for non-utilization, we asked for reasons that were related to the waitlist and those that were not. So 6 of the 9 ODOs indicated that they had not utilized a suitable pediatric or neonatal organ in the last 3 years due to the lack of an appropriate patient on the waitlist. When asked what the reasons were, it was a lack of match in size and age of the donor and recipient, an HLA mismatch, a blood type mismatch, or the unwillingness of the team looking after the waitlist patient to take a DCC organ. And then when we asked for non-waitlist reasons, so these were not that they didn't specifically match somebody on the wait list, but just an overall exclusion. Again, it was positive serology in the donor, age of the donor, unsuitable organs, the fact that the donor was declared dead by circulatory criteria, the physical distance, and the OR timing or size of the donor. So you can see there's a lot of decline of organs related to the type of donation that's coming up across this survey. So then we looked at where are organs being offered. This is a little bit of a confusing slide, but you can see that the organs are offered provincially, nationally, and internationally, and that offering differs within each organ type each organ type by the type of donation. So there's much more willingness to offer organs nationally when they are DNC organs than when they're DCC organs. The differences in provincial offering has more to do with whether or not there is a local transplant program. And then we asked about pediatric specialization in education. So within the ODOs, the majority indicated that they have both pediatric specific donation and donor management guidelines, which is great. When asked about pediatric specific programs within the ODOs, 6 out of 9 indicated that they had a peds or neonatal champion, and 4 out of 6 of those had specific education provided. Only 2 reported that they had pediatric or neonatal specific committees, and only 1 ODO in Canada reported that they had family involvement. And then finally, only 5 of the 9 ODOs reported provision of pediatric specific education to their donor coordinators. When we look at data and reporting, we see that 7 of the ODOs complete pediatric specific potential donor audits, and 4 of those include neonates in that. And of the 7 that complete the audits, 5 do share them outside of their ODO. Similarly to the critical care units, the most common course of action when a missed donor was identified was ad hoc conversations. All ODOs maintain their own databases and report to national and international databases. 4 have a donation database. 1 ODO reported a transplant specific, and 4 reported that they have combined. Interestingly, though the majority collect pediatric specific data, only 4 collect data specific to pediatric wait lists. And then again, when we asked broadly about other barriers and facilitators, the main ones identified by the ODOs was culture of donation, size of the organ donation organization, which with smaller organizations indicating it's hard to have pediatric specialization when they're a small ODO that see very few peds patients. And then they felt that ethical concerns around children and neonatal donations still were a big barrier to donation. So to summarize the ODO surveys, all ODOs offer DNC organs nationally, but only half of them offer DCC organs nationally. Absolute and organ-specific donor exclusion criteria is inconsistent between ODOs. And the most common reason for not offering pediatric organs are organ function, size, and that the organs came from a DCC donor. The most common reasons cited for decline by transplant programs, again, are size, age, HLA match, and DCC donor. Though most ODOs have PED-specific policies, many don't have any specialized training in pediatrics or neonatal donation for their donor coordinators. Most ODOs do perform potential donor audits, but have an inconsistent approach to missed donors. And though most ODOs collect PED-specific data, less than half collect data on patients on the wait list. So now I'm going to hand it over to Dr. Hamiwka, who will talk about our transplant surveys.
Thank you, Laurie, and thank you to the CDTRP. It's really my pleasure to present to you today on our findings. So, as said, we're now going to switch on to the transplant program side of the story. So for transplant programs, we wanted to ask questions about use of pediatric donor organs and if outcome data exists. We also wanted to find out if pediatric organs were being routinely allocated to pediatric recipients, and specifically what criteria was being used at each site to decide if or not pediatric organs were transplanted into pediatric recipients. In other words, do pediatric donation allocation policies exist in Canada? So on this slide, we first had to define what centers we'd include. So our target was to target those pediatric programs for which surgical transplant was done in children and the decision to accept or not accept the pediatric organs was being done. So you may or may not know that most pediatric centers across Canada with subspecialty services will follow transplant patients longitudinally, and some will perform transplant in older children or adolescents along with the adult program at their centers, whereas the transplant surgeries for their younger children may be performed at other sites. So those are not centers that we included. What we included were centers that were interested in those programs that were either accepting or rejecting organs, as well as performing the actual surgeries at their centers. So shown are the centers that were identified and included in the study. The highest number of centers were performing kidney transplants, but all solid organ transplant programs were included. So we had a total of 18 programs over 8 centers. Next slide. So of the 18 programs that we included and sent surveys to, we had an 83% response rate. So only 3 programs didn't complete the survey: 1 kidney program, 1 liver, and 1 intestinal transplant program. Next slide. So to correlate the responses with the program size, we asked centers to provide estimates of the transplant numbers in terms of yearly transplant volumes. So this graph is color-coded by the estimated transplants per year in each program. So light green is around 1 to 5 transplants per year, and dark red is greater than 20. So for example, in heart, one program estimated they did 1 to 5 transplants per year in their program, while 2 did 11 to 15. In lung, both programs were between 1 to 5 estimated. And in kidney was the most variable, with the highest number of being 6 to 10 transplants in 4 centers. For liver, they were both higher transplant estimations, and intestine estimated 1 to 5 per center. So if we, out of interest, if we compare this to core data, our Canadian Organ Replacement Registry, really the numbers do correlate. So we feel these estimates were quite accurate provided by the centers. Next slide. So we also asked pediatric programs at what ages they perform transplants in their programs across the organ groups. And as you can see, generally pediatric transplants are occurring from infancy to 18 years, except in kidneys, where patients are older, usually greater than 2 years of age at the time of transplant. As well, 2 programs reported that they were transplanting patients up to 19 years of age at their programs. Next slide. We then asked centers about organ acceptance. In particular, we asked programs about their absolute donor exclusion criteria for organs, and not surprisingly, we found differences. So next slide, please. So this slide is a summary of the absolute donor exclusion criteria for kidneys. And as you can see, there's variation from for exclusion parameters from donor age, donor weight, whether a center accepts DCC donors, and HLA matching, as well as other categories such as organ function and expected cold ischemia time. The only clear agreement across the kidney programs was they do not accept organs when there is a high level of either class 1 or class 2 HLA antibodies. Next slide. For heart, we saw similar differences reported among the categories. All 3 heart programs did consistently report their willingness to accept high-risk donors, those with drug use or unknown sexual history. But apart from this, there certainly were differences, some significant and others less significant, but yet we did see differences. Next slide. For liver, the same, we saw similar variations, but centers did agree not to exclude organs based on HLA matching for liver. And next slide. In terms of lung showed the least variable responses. Similarities included that they both accept and do not exclude DCC donors. Cold ischemia was not an exclusion, as well as the presence of class 1 HLA antibodies was not an exclusion. Next slide. We then asked a separate question about whether programs would accept pediatric DCC donors. This slide summarizes programs' acceptance for DCC donors by organ type. So if you look at the first circle, that's for heart. So one program said they would accept DCC donor for any recipient, while another program said they would only consider it for a status 4 or someone on ECMO with high intensity support and a survival expected for less than 2 weeks. In lung, there was no specific criteria, and both centers would accept pediatric DCC donors. In kidneys, once again, we had the most varied responses, and perhaps that's because we had the most centers that were responding. But only 4 of the 7 programs stated they would accept a pediatric DCC organ. And they specified details around this acceptance being specific time to death, if the organ was deemed not a high risk for acute kidney injury following transplant. Some stated criteria for HLA matching, minimum, such as minimum of class 2 or matching, and some discussed also warm ischemia time. In liver, one program would consider a pediatric DCC donor, but they went on to say that it would have to be perfect and only for a patient in urgent need of a transplant. And finally, our intestinal transplant program would not accept a pediatric DCC donor. So of interest, and not shown on this slide, when we asked about adult DCC organs, only one lung program would accept an adult DCC organ, while 5 of the kidney programs would accept an adult DCC organ, which I find very interesting because only 4 of them would accept a pediatric DCC organ. So we definitely need to explore that a little bit further. And all the other programs would not accept an adult DCC donor organ. Next slide. We also took the opportunity to ask programs about their use of ex vivo technology for pediatric donor organs across the various organ groups. Certainly ex vivo is being used, but it does vary, and I suspect this is very similar to the adult programs. Next slide. We then went on to ask about organ allocation. Next slide. We specifically asked programs to tell us about factors that inform practices in Canadian pediatric transplant programs. These factors included, as shown below, national allocation policy, local allocation policies, informal allocation guidelines, expert discussion, or a priori patient lists. 4 of the programs listed that they only use one factor, while all others reported that they use more than one. And as you can see, national allocation policies were used universally across programs, except, always the exception, for kidney transplant, which used local allocation policies. They did use some national allocation policies, and I assume that's probably because we have a national highly sensitized transplant registry, and we have national paired kidney donation exchange programs. Despite these policies, all programs except intestinal transplant reported expert discussion to be used in allocation practices, and lung also reported the use of a priori patient listing. Next slide. We asked about specific policies for pediatric donor organ allocation, and only 53% of programs had such policies. For the programs without specific policies, they reported using provincial transplant program guidelines. Others used case-by-case discussions. Other programs did say that they unofficially have a policy that follows the rule pediatric donor organs are given to pediatric recipients first. And one center went on to elaborate that it can really depend on the discussion with the surgeon, whether this does go forth. Next slide. Then we asked programs about their collection of pediatric transplant data and reporting of this data. Next slide. And 14 of the 15 programs report data to either local, national, or international registries. 80% of the transplant programs are collecting data on death of pediatric patients on the transplant waitlist, while only 60% collect data on removal from the waitlist for deterioration in clinical status. 73% of the pediatric programs stated that they collect pediatric specific data. This slide represents data collection of short and long-term post-transplant outcomes. Each organ group is represented by a different color as shown along the bottom. From the survey, we can see that short and long-term post-transplant outcomes are being reported and captured mostly locally or in hospital databases, as well as data is being collected frequently in international databases. But national and provincial databases, this data appears to be lacking. So this really highlights the specific data about national outcomes of pediatric donor organs is not possible at this time. And in Canada, we do hope soon, it's being worked on, that a national database will come to fruition as planned. But obviously it's going to take a long time for that data to accumulate. Next slide. We also asked about barriers and facilitators. And so 20% of programs reported insufficient information on the pediatric donor to timely accept the organ. The most common missing information was imaging studies or lab parameters. Next slide. And programs were asked about logistical reasons that resulted in declining a pediatric organ offer in the last 5 years. The reported reasons are listed on the left-hand side with the number of programs who listed the reason in brackets. So the reasons included lack of timely transport, lack of patients on the wait list, lack of available retrieval staff, recipient location, other, because we did this at the time of COVID came up, financial restrictions. We were happy to see that 6 programs reported not declining a pediatric offer over the past 5 years for logistical or surgical resources. We also went on to ask about other barriers to pediatric donor acceptance, and these included logistical difficulties with rural donors and lack of availability of donor coordinators, causing inefficiencies in acceptance of allocation of organs. And we asked about facilitators, and what was reported included the availability of donor coordinators and donor specialists in critical care. So overall, we can say that organ acceptance criteria, including pediatric donor criteria, is reported to be variable across Canadian pediatric transplant programs. Many programs in each organ group, except lung, do not accept DCC organs. There's lack of agreement on organ-specific absolute exclusion criteria. Not all pediatric transplant programs collect pediatric-specific data, and data on pediatric death or withdrawal due to deterioration is not uniformly collected. Excellent. So in conclusion, I think we can say that this was certainly an interesting undertaking and has highlighted many important points in pediatric donation, as well as pediatric transplantation in general, and the acceptance of pediatric donors for pediatric recipients. Obviously, it doesn't tell the full story, but certainly does start the process of knowledge and sharing of information and processes between our three vital groups that are working together to make transplantation successful. So given our survey results, at the current time in Canada, there appears to be variability in pediatric and neonatal donation and transplantation at all levels. We found evidence of inconsistent access to pediatric donation for bereaved families, as well as inconsistent access to potential organs for waitlisted pediatric patients. At present, but hopefully soon to be improved, there's insufficient information on waitlists and outcomes for transplanted patients, including pediatric patients with pediatric donor outcomes. Next slide. So lastly, I just want to say thanks to each of you for attending and for the CDTRP for allowing us to present our survey and our findings. We truly hope to answer some of your questions, and we also very much look forward to your thoughts on next steps and where do we take this? Where do we go from here, finding out this knowledge? So thank you.
So I would welcome any questions and comments to our presenters. Thank you so much for your very valuable work that you've done as a transplant recipient family. I can appreciate how much is done behind the scenes in listening to this. It's quite impressive, and I feel even more fortunate that we actually ended up on this side of getting a transplant. So again, I'd like to open up the floor to anyone who has any questions. You're welcome to use the raise hand function so I can find you. Yes, Erica.
I have I think it might be a basic question, but I don't know the difference between DNC and DCC.
Sure, I can answer that. That's a great question. I'm sorry we didn't review that in the beginning because that's an important one. So DNC stands for death by neurological criteria. That's the traditional way that patients needed to die to be able to donate their organs historically. And you have to meet some rigorous testing related to a really significant brain injury that shows that there's no function left in the brain. And patients are declared dead by neurological criteria through a series of tests that are done in the ICU. And then they are approached for the opportunity to donate. And if the family consents, then organ retrieval happens at that time. And that's actually quite rare. And so in recent history, it's not that recent anymore, maybe a decade ago, we started to move more towards donation after circulatory criteria death. And that's where we have patients still usually with a really catastrophic neurological injury, but don't meet the full criteria for death by neurological criteria. And the family decides to withdraw organ supports to allow the patient to pass away. And when their heart stops beating, they are then declared dead and we're able to retrieve their organs at that time. So it's really just about the way that they are declared dead. Why it matters from an organ acceptance perspective is in death by neurological criteria, the heart is able to be kept beating until organ retrieval happens, whereas in death by circulatory criteria, the heart stops beating for a period of minutes before organ retrieval happens. And so there can be actual and perceived differences in the organs after transplantation, depending on the way that death is declared. The evidence on that is still coming as to whether those organs are truly different, but that's one of the reasons why the acceptance is different between those types of death. Does that make sense?
Yeah, thank you. Very well explained.
Thank you, Laurie. Matthew?
Thanks. And I'll just add to that last comment before I get started, is that many more children die after withdrawal of ventilator support than they die by death by neurologic criteria. So the pool of potential donors is a lot bigger from circulatory death, even though most systems have either not or underdeveloped their DCD programs. So anyway, Thanks, Laurie. Obviously love this presentation, love that, pediatric donation getting pushed forward. So understanding, and I'm kind of building off also what Laurie is putting in the comments, that there are obstacles at every level. So if we're talking strictly about having better numbers, okay, let's imagine a world where you are given a magic wand and you can eliminate one of two classes of obstacles. And one class of obstacles is that the programs would have better IT infrastructure to be able to share, to be able to collect and share their data, because a lot of the problems that we don't have good pediatric data is that it's just not collected in a uniform way, and it's put on all these different platforms that don't talk to each other. So that's one kind of category of problems. The other category of problems being that there are legal or regulatory restrictions to provinces sharing this data, especially when it comes down to small sample sizes, small cell sizes, that there's the potential for back identification of patients, et cetera, et cetera. So they get squirrely about giving pediatric data. So which one of those classes of problems, either kind of logistic IT problems or legal and regulatory problems, do you think is a bigger hurdle for, and you would wish away first if you had to, if we're building this, national pediatric data set that we need?
So I'll start, and then Lorraine, why don't you add in, because we may have different opinions. For me, looking at all of the surveys sort of uniformly, the problem that seems to exist across the board is the lack, exactly to your point, Matt, of optimization of donors from children who die by circulatory criteria. So we know that pool is way bigger, and yet it still, this year, represents a very small portion of the organs that are retrieved and transplanted. And when I look at the barriers that are identified in every level of the surveys, it is either an acceptance or a willingness to donate after circulatory criteria. And I think having uniform data on the quality of organs from DCC donors is probably the first step, because the PICUs are going to be reluctant to push forward with DCC through the logistical and ethical barriers that they face if they don't know that those organs are going to be accepted and utilized. And the transplanters aren't going to transplant those organs if they don't know that the quality is going to be good for their recipient patients. So I think that question and answering that in a uniform and rigorous way ables trickle up or trickle sideways across all of the programs to really optimize what I think is the largest pool and the most underutilized pool. So that's my answer. I'd love to hear what Lorraine has to say.
Well, I think some of the issue lies in is we just don't have the data, so we just don't know, like, why do we have all these programs having such different criteria for accepting of organs? And a lot of our data, say in kidney, because I'm kidney, we have hesitation to sometimes take these DCC kidneys because in adult data, sometimes they don't work that great. But kids are different. They're younger. They don't have all the chronicity but we just don't know. So there's this hesitancy. So it comes down to sort of people collectively perhaps setting some criteria of taking these organs and coming to some degree of consensus, but also having the data to show that these organs do, or perhaps do not, we suspect do, well. And so, one of the next steps in our thinking of this project is, can we somehow look back and look at these pediatric organs and see how they did to show people that they in fact do well? We have no way to know how pediatric donor organs do in pediatric transplant recipients. We do have some information, and I'm sure some centers can piece some together. But as an overall perspective on a national basis, we just don't have that data.
All right. Just before I get to Anne, I noticed there's a question in the chat that relates to this from Wendy, indicating, what is the plan moving forward to standardize the identification and referral process? So just before we move on, just wondering if you wanted to add anything to that. I know we talked a little bit about data, criteria, uniform and vigorous opportunities, but anything else you'd like to talk about standardizing the identification and referral process?
Yeah, a parallel project with this group is actually a Canadian potential donor audit, which is the first step in standardizing that identification and referral process. And so we are currently collecting data on that. About half of Canada has been collected. To Matt's point, it's been hard because the numbers are small and sharing data from province to province is hard. So that's gone slower with the pandemic than we had hoped. But the first step is really identifying what's the problem. So how many patients are being missed and where. And then we plan to do some triangulation between the results of those audits in units and compare those to what we've learned in the surveys about programs and mandatory referral and referral criteria, and see if we can tease out which units have high rates of missed donors and which have low, and if there's ways we can target that specifically. One of the things that's difficult with standardizing identification and referral is law. So different provinces have different laws around referral, and that's not consistent across Canada. And so there's a lot of work done in each of the provinces from donation advocacy organizations to work on mandatory referral, which is one of the main fixes for that.
Perfect. Anything to add, Dr. Hamiwka?
No, I think Laurie's the expert on that one.
Perfect. Anne?
Thank you both for such a great presentation. That's not like a perspective I get to see very often, so I really appreciated that. I know Lorraine knows me. Laurie, I don't know if we've met before. I work in the HLA lab in Edmonton, and so I noticed that, that came up a few times, and maybe this isn't a major barrier, but I'm just wondering, I mean, that you could tackle from this angle, but was there something specific you noticed when collecting these data that HLA labs could do to help with any HLA antibody related barriers, or something that was sort of identified as something that the HLA lab could do to support removing any of those? I mean, we can't remove antibodies, but is there something we could do to, identify those patients or facilitate matching earlier? Any thoughts?
Good question. I'm not sure there's anything that I have right offhand. I'm happy if anyone else has any ideas that they want to share. But it is interesting how the HLA, again, is varying so much across all the organs and across the programs. And, coming to some consensus would be great, and certainly obviously would help the HLA lab with the matching. But, I think it's more center clinician opinion driven at this point in time than anything, that the HLA lab can modify. But if anyone else has any other ideas, please, I'm happy to hear them. Or if you do, Anne, perhaps you do.
I don't know. I think for things like the kidney paired exchange, obviously the HLA labs worked really hard at that time to try to standardize, how we were doing things for that. But it is, as you said, it's different. Not every organ group has the same HLA needs, and not every program has the same HLA needs. So certainly, I hope that we're not contributing in any way to, adding any extra barriers that make it even harder. But yeah, if that ever comes up, I hope that it would be brought forward to the Canadian Blood Services as the HLA working group, and that would be a great place to maybe bring this to. I'm not actively participating in that group, but I know every HLA lab is represented there. So I think they're actually meeting in person this week. So anyway, yeah, thanks so much again. It's a great presentation.
Thanks for your comments.
Linda?
Hi, congratulations on the presentation and the research. This is certainly putting a spotlight on the opportunities and the challenges. And you brought forward so many pieces, standardized policies, data collection, education, resources. But I'm certainly putting a vote in for much professional and public the more it drives questions and then drives push for the policies and the resources to put everything in place. So congratulations, look forward to the next steps, whatever they may be.
And just going through the chat, really noticing some comments from Laurie indicating sobering, compelling, and missed potential of donor. So I think that's really good. Matt, you had additional comments. I see no other hands.
Well, like I said, if somebody else has something, I already had my turn, so I don't want to. But I building off of what Lorraine said earlier, I think there's an opportunity, and I've had this thought on a couple different spaces in donation and transplantation. I wonder if we brought in a game theorist who could really sit down with the transplanters and the donation folks and talk about, look, how do we weigh the risk of this unknown risk of graft dysfunction from a potential pediatric DCD donor and weigh that against the wait list mortality of someone not getting an organ on the wait list, and really kind of go through some formal game that out in a formal way, because we do it informally all the time. But I really would be interested in someone that's their job, is to game these kind of things out and see what would that look like in this decision-making process. So I don't know, Lorraine, or if Laurie, or I see William, you got your hand up about this. I don't know if it's in relation to that. I think there's a lot of opportunity there, but go ahead, William. I'm interested to hear what you say.
The reason I pick on this is that you asked both questions and they both go into a contradiction. Sample size. Without the sample size, without sharing the data, you can't answer any of these questions. So yes, you can bring in game theory, but game theory without supporting data, there's nothing you can do with it. That's the problem. So data sharing is important. There is a little bit of hope somewhere. There is this idea of generating synthetic data based on real life data, where you can take a small pool and extrapolate from it, hopefully relevant information, and start generating these patients, these cases that look similar to what you have in the original pool. So number one, no legal issues, no privacy, no trouble of that kind. And number two, hopefully as closely relevant to what you're dealing with as you can probably solve. But without solving the data sharing issue, there is not much hope. That's the problem.
And I think, like, to end on an optimistic note, this is the first time the pediatric community has really come together to look at what we're doing. And I think being able to highlight the variability and the heterogeneity is a bit of a call to action. And so as we do these presentations and start to publish some of these results, I think we're hopeful that it'll be sort of the kick in the keister to get the kidney programs together and the donation programs together and get everybody together to say, we're stuck with a small sample size, which is great. Not a lot of children need organs, so yay. But let's do the best for the ones that do and make sure that we're consistent and cohesive and collaborative. And certainly there's been nothing but positive responses from everyone involved, from the critical care units through the ODOs and transplant programs, and a real desire to do better and make it better. And so I think we have enough evidence now to really push forward an agenda of having to collaborate to address that sample size in whatever way we can.
I see that we're at the top of the hour, so I'd like to thank everyone for your questions and comments throughout today's presentation. Dr. Hamiwka and Lee, on behalf of CDTRP, thank you again for presenting. If anyone has any additional questions, comments, or suggestions, topics, and speakers, contact Erica Croft at ekcroft@cdtrp.ca. Thanks, everyone. Enjoy the rest of your day.